good. Going to jump right into it. Club news. Karen, you probably have something to share a little bit, just an update on our whole allergies thing. Yeah, let's do it.
Okay, so I just want to tell you about one of the invasive projects that we have going to remediate invasive plants. So we're working with the BFA Ecology Department and the Interact Club. And our plan is twofold. One is to approach Stevens Brook, where the ballpark is, and Aldous Street, to remediate the knotweed there and the buckthorn. We have the forestry department that's on board. We're actually going to start working with the city manager as well. And the other thing that we're going to be, that'll be done in April-May timeframe. We're going to ask probably the Rotary Club to give us some help, because in order to remediate knotweed, which is horrible stuff, whose rhizomes can go 10 feet down, they need to be cut twice a month. So I won't be able to get that done through the school during the summer. So twice a month, we'll probably ask some of you to come and help us cut it. It won't take long. It's probably a half-an-hour job.
Good service project. Good.
The good service project. Cool. The second thing they're going to do is the ecology department. We're going to obviously help provide them some money to do the work, because we're going to have to plant some shrubs and some trees there to create some overstory. The other thing we're going to be working with them on is they're going to take and they're going to attack Congress Street. The kids are going to attack Congress Street, Fairfield, Bank, and a number of those streets around there. They're going to walk the residents and identify those plants that are invasive that people have planted or don't know that they have, and we'll provide them with a flyer that tells them how to get rid of that and what to replace it with. So
awesome.
That's it.
Good stuff. Good work.
Karen, I've got some invasive knot heads that I'd like.
Oh boy.
I'm sure Kevin is saying, "Oh man."
Yeah. Good one. Good one. Actually, yes. Go ahead, sir. I was going to remind you about that expo.
Okay, yeah, just in regards to the silent auction, I appreciate everybody getting back to me with the emails and people starting to put in their items on the spreadsheet. Thank you so much. One of the feature items for the past few years for the grab bags will no longer be with us. Efficiency Vermont is unable to donate the light bulbs this year, so if anybody has any ideas for such a thing such as that would be great. We do have some cool items going in there, but we definitely do need more. We are doing 600 of them this year. So definitely keep that in your mind as you're making requests, or if you know people. So appreciate it. Thank you.
Nice. Good. And as a reminder, the ticket sales, make sure you're selling your tickets. I'd like to get the minimum 10, but I'd like to maybe shoot for 20 plus each person. That could really bring in some revenue for the show too. Joe could make it today, but he's going to be starting to give us updates on like the booth sales and everything. He's going to give us a really small synopsis each meeting moving forward, starting next week. So that'll work. Does anybody have any community news? Yes, John.
Well, it's finally here tomorrow. I start the LA program for the fall, and it's Fred Weissman out of Swanton talking about the fact that Swanton at one time had a big employer of making ammunition. And if you didn't know that, well, you can find out about it tomorrow at 11 o'clock.
All right, good. Thank you, John.
And that's right beside my office, and we still have fireworks.
Just inside now. Sorry, I said that.
Yes, sir.
So, Alan, next week, of course, is Shrove Tuesday, Fat Tuesday, and
Yes.
we're having a pancake supper at Holy Trinity, combining with St. Luke's here in St. Albans. So we'll be up at Holy Trinity. It's at 5:30 to 7. If you'd like to take advantage and clear out your closets, which is your fatty foods for Lent. But also on Wednesday, I'm going to start something new for our area. It's Ashes to Go. So from 12 to 12:30, I'll be out in front of the church, and if people can't come to the service at 5:30, they can grab a hot chocolate, a little bag of Lenten goodies, and get their ashes.
Oh my. That's really.
Blow right in.
That's really cool. That is really. That's really good.
Friends, they don't want to be in church. They want to get ashed.
I might go take a picture of that. That would be kind of cool. Yeah, that would be kind of cool. Good stuff. Any other community news? Anybody have anything? No. All right, so let's go for our quote of the day. Bert, you ready for the quote of the day?
Ben Franklin was known to say, an apple a day will keep the doctor away.
That's a good one.
It's true.
Steve, you have a quick one?
I do. This is a word that I live by. We have found that it's much easier to restrain our wrath when the other fellow is bigger than we are.
Good one. All right, without any further ado, I'll invite Rob up to do your part. Thanks.
My name is David Gervais. I'm the Director of Diagnostic Imaging at Northwestern Medical Center. Been in that role for about 4 years now. I'm here with Chelsea Mulheron, who's our breast care nurse navigator. It's a role that's relatively new to NMC. It's been about 3-4 years now that Chelsea's been in her role. Her role is primarily aimed at helping women and men through the breast care world, from meeting them at diagnosis of any issue through treatment and recovery. We've introduced a lymphedema program that we're doing through collaboration with our physical therapy area. Just a lot of great innovation going on with this program, and we're happy to present to you today. And I just want to say we have a large portion of men in this group. Breast cancer can affect men just as much as women, and it's important to hear out the message. And what we're going to be talking about today is some myths around mammography and how we can dispel them. So with no further ado, send it over to Chelsea. Oh, we're loading.
It's still loading. This is a typical thing. I'm Chelsea Mulheron, as David mentioned in the video. I'm the breast care nurse navigator. I've been at NMC for 15 years. My first 12 were in the ER, and then I said, let's change things up and see what else is there. And I saw this ad for the breast care nurse navigator. Had no idea what a breast care nurse navigator was. You guys are a pretty fun bunch. Anybody have an idea of what I would do? Navigate what?
Care.
So, exactly. So I navigate care for women, for men, relating to the breast. So it's kind of a brand new program that the hospital. Can you guys hear me okay back there? There's a brand new program that the hospital was developing, and so I took it on with David, and we created this amazing program. As part of, those are my loves. So as part of developing this program, one of our goals was to do community outreach, to get patients in, to get their mammograms, to stay up to date on preventative health. So we decided that we needed to find some funding. We couldn't just do this out of David's budget. So we got Susan G. Komen grants. We wrote a grant for Susan G. Komen that we were going to outreach to the community, to anybody who wanted to hear me. I've been to Walmart, I've been to Superior Ceramics, I've gone to supervisory unions, and now I'm here with you. So we just wanted to promote breast health, what it is, and what you can do to help yourself, your family members, your loved ones, anybody in your life. So we've tackled this myth busting. There's tons of myths when it comes to mammography. David, in my bag I have a pamphlet if people can't see them. I printed off the presentation. Poor John has already told me that it's difficult to see the way I printed it off, so I apologize ahead of time. So we do the common myths of mammography. Anybody know why we are using the number 8? So 8's a very significant number when it comes to breast cancer. 1 in 8 women will develop breast cancer, regardless of their background or history. It's just a spontaneous change. So 8 is a very important number to us. How many women do we have here? We've got 4. So it's a half of 5 of you. 6, 7, and I think there's an 8th woman in the kitchen. So if we statistically look in the room, 1 of us will develop breast cancer in our lifetime. It's kind of a scary statistic. So if you're at your next family outing, you count in your room how many women you have in your room. If you have over 8, 1 of them will get breast cancer. So our objectives today is to identify that mammograms are helpful. Right now there's a big controversy between 2D and 3D mammography. I'll get into doing the difference between the two of those, but we'll discuss that. There's a lot of common fears and worries about mammography and breast cancer, so we'll talk about that. And my goal is to empower you to either get your mammogram or to educate someone to get them. We want everybody to be informed and make sure that we're all doing what's best for our healthy lives. So myth 1, Jeff had told me that the 2/3 of you were going to be male. So I've kind of changed my presentation a little bit, which has been great. So men don't have breasts, therefore they cannot get breast cancer. What do you guys think about that? Thank you very much. I hear it all the time, though. So, in fact, men do have breast tissue. It's just not as much as females do. And men are at a 1% risk of getting breast cancer, so your risk is still there. So our biggest thing is to know your family history. That's going to increase men's risk for breast cancer. And if there's a genetic mutation in your family history. So those are really important things, just to know your family history. And being aware. We always say be aware of your body. Be aware how spots look for skin cancer. So just be aware how your entire body looks, feels. And if there's a difference, that's when we go to your primary. So I just wanted to illustrate, and it's kind of hard to see a picture. One of the biggest concerns with men, not breast cancer, but gynecomastia, it's an enlargement of breast tissue. They come in all of the time very scared, and we want you to know that that's okay. We're here to help you. And that's usually done with a mammogram, diagnosed on a mammogram. So yes, men can get breast cancer. So we've busted that myth. Mammograms are painful. So this is a common one. We hear this all the time. Why aren't you coming in for your mammograms? They hurt. So this is what people picture when they get a mammogram. Your breasts are in a vice. This is truly not what happens. Correct? So we talk about pain being, and it's a subjective thing. It's what people feel. So it's not that I can say, well, your pain is different than mine. Everybody has their own threshold. So we really try to make sure we know what your threshold is and what you can do. Everybody says, well, I don't want compression. You've got to have compression. We need it. That's to get the best imaging possible. We don't need to flatten you like a pancake, but we need just to hold you still. So there will be compression. And yes, men, there is enough tissue there to put you in compression. You wouldn't believe it, but our technicians are amazing and they do a great job. So we always tell women different things. Menses is a big thing, and that can change how your breasts feel. So if patients are starting their menses, they may be more sensitive. So always ask that question and do that with scheduling too to make sure their cycles are okay. So we've busted that myth. Any questions so far? You guys are still with me? So myth number 3. I have no signs of breast cancer or family history, therefore I don't need a mammogram. We get this all the time. I don't need to come in for my mammogram. But this is a huge statistic. 90% of breast cancers have no family history. It's just a spontaneous gene change. So it's nothing that we can control. We can't tell you, yes, you're going to get it. No, you're not. It's just a spontaneous gene change. The great thing with 3D mammography is that we're picking up these breast cancers a lot smaller and a lot earlier. So we talk about 3D and 2D mammography. Does anybody know the difference between the two? Anybody heard about 3D mammography? So 2D is literally just 2 pictures. The 3D is a whole sweep of imaging of the breast. So we've gone from 4 images to, what was our final number? Did Karen say? Like 120 images per breast. So we're literally slicing the breast up like a loaf of bread, and you can take images out just like a loaf of bread. So this has been a huge advancement in mammography. We talked about our 1 in 8 statistic. So even though you don't have that family history, you're still at risk. And out of those women diagnosed with breast cancer, 3 of them will have no family history. So 75% of diagnosed breast cancers won't have that. So it's kind of a really crazy statistics. So we're almost halfway through. We're doing great. So I've already touched base on our 3D mammography, and is it the same? I've already given you that answer. So definitely not the same. Takes the same amount of time though, which is great. It's just 2 more seconds. It's amazing. I talked about how the images come out in increments. They're actually 1 millimeter slices of the breast is how they're slicing this up. So this is really great for our radiologists to be able to view these images. Currently we're not charging for this additional imaging. It's some insurances are accepting it, some aren't, so we just want our patients to get the best care. If your insurance doesn't accept it, we're just not charging you for it. because it has been proven to show that it has detected cancer a lot earlier. There is a slight more radiation in this versus our 2D, which I'll get into. So this image, I don't know if it's kind of difficult to see. It's a 2D image versus one of our 3D slices. When you look here, this is just dense breast tissue. We call it the white clouds. So it's just dense stuff. You really can't see anything in it. And that's the issue with 2D mammography. It's hard to see through that dense tissue. Whereas when you take the 3D mammography and you're literally slicing through it, now you see the circle here. That's a mass. That's a tumor right there. You can see it's circular. Whereas here it just looks like regular dense tissue. So those are the tiny cancers we're picking up now. I keep giving away the answers ahead of time. I apologize. So, will this expose me to unsafe levels of radiation? So, the FDA actually regulates mammography. That's one fact I had no idea, and a lot of people don't know. So the federal government actually regulates the amount of radiation and what we do in mammography. We just had our inspection yesterday, which we passed with flying colors, which was great. They also regulate our 3D mammography. So their regulation is to make sure that we fall within the standards of radiation. The 3D dosing is just a tiny bit more than the 2D. You can see the 2D is 0.4 MSVs. I'm a nurse, not a radiologist, and David can always tell me what that stands for.
Yeah, I serve as the hospital's radiation safety officer as well, and that's a unit of dose that if you're exposed to radiation, that just millisievert is what it stands for, more than you need to know.
So really educating you today. So just from walking around, being out in the sun, doing our gardening, being in our homes with our microwaves, our Wi-Fi, we're exposed to 3 millisieverts of background radiation. That's just something we can't control. The radio airwaves, it's just what's there. So if you compare it to what we're normally exposed to without doing anything extra, this is really tiny, our amount of radiation. So the 3D mammography just gives you 8 weeks of background radiation. No difference than a trip on an airplane from here to California. People don't realize how much radiation you actually pick up in an airplane because of all the airwaves. Do you have a question, Karen?
No.
Okay.
No good.
So no difference in radiation, just a tiny bit more, but it's not going to make a difference. It's life-saving. 1 week of extra background radiation versus not detecting breast cancer. I mean, let's weigh our risks. So myth number 6. I had a normal mammogram last year. I don't need one this year. Any thoughts on this one? Anybody hear anything about what's been going on with this question? So this is a huge discussion. We have different societies in the medical field. We have the CDC, which is usually the federal government. They partner with the U.S. Task Force. We have the American College of Radiology. We have the Cancer Society. All these people, and the other one is the OBGYN Society. They all have different standards for mammography. This is really confusing people. So it's part of my education is to know when you need to have your next mammogram. Each provider follows a different society depending on where they belong to. Our radiologists, they say every year after 40, women need to get a mammogram. The U.S. Task Force says after 50, you can get one every other year. Between 40 and 50, you can have one every year depending on your family history. And so we are just telling our patients to do what you think is best for you, what you feel comfortable with. We have women that come every 366 days because they know their insurance covers 366 days. They are there every 366 days. We have women that come every other year. They said, I don't have a big history. I'm comfortable coming every other year. So it's really what's truly best for you and your history. And we just recommend everybody talk to their providers. So myth number 7. I get called back from my screening. I'm going to have breast cancer. I don't know, a lot of you haven't had your mammograms before. What happens is women come in, get a screening mammogram. Their mammogram images get read within a day, and if there's any concern, they get called back. So they all think that they have breast cancer. Luckily, that's not true. They don't always have breast cancer because we call them back. We call 3 to 4 women back a day. We do about 20 patients a day. So 3 to 4 is not a lot. There are different issues. Sometimes it's skin fold, just some asymmetric breasts, dense tissue, or even a mass. When people hear the word mass, what do you think of? Cancer. That is not true in breast imaging. There are cysts, there are densities. Mass is a very vague word in radiology, so whenever you hear the word mass, don't assume it's cancer right off. And the great thing is, patients come back for their additional images, they get their results right then and there, so there's no longer a waiting game. So the radiologist meets with them at that point in time. All right, number 8, you've done great. Back to my doctor didn't tell me that I needed to get a mammogram, so therefore I don't. So this goes, what do we think? I'm not letting anybody answer questions today. So this goes back to what your preference is. Our recommendation is anybody over the age of 40 gets a mammogram. You don't need an order from your doctor for this. This is a state law. This is a law that went into effect years ago that any woman can get a mammogram after the age of 40 without needing an order from their physician. It's the only type of imaging you can get without a physician order. I talked about how we schedule exams every 366 days. Some people know their insurance do a calendar year, and then they schedule it differently. So just being aware of that. And part of my education when we meet with a lot of women is that if you have a problem, don't come for your screening. Go to your doctor, get checked out, and then come in and get the full workup like you should be. It's more beneficial. So that's one of our big education things is women show up and say, oh, I have a lump. Like, well, you need to see your doctor. We want to do what's right for you. So that's all of our myths. So we've busted that mammograms are helpful, they're beneficial. Anyone can get a mammogram, male or female. The males do need an order because usually it's a diagnostic. 3D mammography does have a little bit more radiation exposure, but not enough to deter you from not having a 3D mammogram. And then we like to address everybody's fears and worries because each person's different. So if anybody or you know anybody who has a fear or worry, let us know. And then we want everybody to sign up and get their mammograms. And I've been doing some research about transgender and about men with breast cancer. And so it's a big thing. So just knowing what's going on for everyone is to be important. These are some frequently asked questions. How do I schedule my mammogram? You can call us at the hospital. Here's our number, and we can schedule it. Georgia Walk-in Clinic has a mammogram machine. You can literally walk in and get your mammogram. No appointment. You don't need to call ahead. They're phenomenal there. As part of the Susan G. Komen grant, we also have funding for people who can't afford their mammograms or any of their breast imaging. That funding goes from screening all the way to diagnosis of breast cancer. So their screening, their biopsy, their additional views, which comes into thousands of dollars per patient. So it's a great resource. We also have funding for transportation. So if you know somebody who doesn't have a ride down, we have funding for that. And David had mentioned our new lymphedema program. This has been a phenomenal program for our women who have been diagnosed with breast cancer. They meet with a lymphedema certified therapist 1 week before their breast surgery and then a month after. They talk about what lymphedema is, how it affects them, and exercises they can do to prevent it. And we've had about 5 women go through it, and they've loved it. It's actually, one woman got to do her radiation therapy 3 weeks earlier because she had great range of motion. So we're just really promoting these positive preventative programs.
Can you just explain what lymphedema is?
Oh. So the concern with what lymphedema comes with breast cancer is during breast surgery, they actually take out a couple lymph nodes along with the breast tumor. So once those lymph nodes are cut out, it deters the flow of lymphatic fluid from the breast into the arm, and it makes the lymphatic fluid hard to get out of the arm because it's been cut off to get out. So it's a really high, I'm trying to think of my wording, because they have a high probability of getting lymphedema in the arm. So range of motion, moving the arm really helps the lymphatic flow. And after any kind of surgery, nobody wants to move. So it's really promoting the exercise, moving your arm. So we want to to stop people from getting lymphedema. And lymphedema isn't something that kind of comes and goes. Once you have it, it stays with you. So prevention is one of the biggest things for lymphedema. So the more that we can educate and improve in their exercises, the better the outcomes are. Giving you a lot of information, and I've tried to get it in my 30-minute presentation into 20 minutes. So does anybody have any questions? Go ahead, John.
Is breast cancer kind of aggressive? I mean, there are all kinds of cancers. For example, prostate cancer for men. Usually, when you're older, you run down something else before that. So, is breast cancer an aggressive one?
Breast cancer can come in different forms. It can be aggressive, and then it cannot be aggressive. So usually, if it's found earlier and smaller, it's less likely to be aggressive. When it's been sitting around and growing, that's when it becomes aggressive. There's also, all tumors are checked, so they check for hormonal levels. I don't know if anybody's ever heard of like a triple negative tumor, which is negative for estrogen receptors, progesterone receptors, which are hormones that fuel these tumors. If they're negative for those are the more aggressive ones, just because it's harder to treat them. So the answer is yes, there are some that are more aggressive. And the longer you wait to find a breast cancer mass, the higher risk you have of it spreading to the lymphatic system, to the lungs, to the bones, and to the brain. So those are kind of where it goes. So that's why we always take out lymph nodes to make sure it hasn't started to metastasize anywhere, because that'll be the first place it'll go. Great question, John. Go ahead.
You mentioned calling people back after the mammography, and is it an ultrasound that's done sometimes to do for the diagnosis? And what is the successfulness of, or the rate of successful diagnosis with the
So
ultrasound?
depending on what is found, if it's a density versus calcifications, there's usually another mammogram, which are spot compressions. They use different paddles to compress to magnify the tissue there, and then it's usually followed by an ultrasound of the area of interest. So with those two exams combined, the radiologist takes all those images and looks to see what we can find there. So usually an ultrasound, out of those 3 to 4 women a day that we biopsy, we do callbacks on, we may biopsy 1 or 2 a week. So, and that's just that they see tissue that they don't really know what it is. So instead of saying we don't know what it is, come back in 6 months, let's just test it, see what it is, and we'll know in a week, and then we'll know what to do.
Biopsy is different than ultrasound?
Biopsy can be done under ultrasound, and it can be done under mammography. That's just tissue sampling.
Okay.
There's certain types of tissues that are more easily visualized using ultrasound rather than an X-ray radiation or mammogram. So it's just kind of like a dual approach, making sure we're covering all the bases.
The question I would have, especially since I've done my Ancestry.com and all that, now they have 23andMe, and they'll look at your markers to tell you what, like, I haven't done that one, but the likelihood of family diseases, etc. And we've heard about stars who've had mastectomies because their family history genetically showed that they were predisposed. So how are you finding the science behind all of that? Because we had a lot of talk for a while and haven't heard anything in a while in terms of genetic predispositions and how women and men should take action based upon that.
So with the genetic predispositions, we actually assess every single patient for that when they come in. We're a member of the Vermont Mammography Registry. So one of the big family histories is Ashkenazi Jewish descendants. They're from Eastern Europe. They have a high rate of a BRCA2 mutation, BRCA1, BRCA2 mutations. So those patients are already at high risk. So we assess for them. And once they've been identified, we are actually piloting a genetic program at the hospital through mammography. So we can offer to do genetic testing through a lab company. So we're also identifying anybody else with other high risk. So high risk is the ancestry background, breast cancer in your family, pancreatic cancer, that's another big one that's in the family, and just multiple colon cancers. So we are assessing those patients as they come in and offering them genetic testing. And then once they become positive, if they're positive genetic tested, then their screening changes tremendously. They get screened more often. Go ahead, John.
Well, I never knew what lymphedema was until I got diagnosed with it about 2 years ago on my foot, my right. So now compression stockings are my norm, and I would appreciate that if you had that issue with your arm, your hand, that putting a compression on it would certainly affect your style, your dress. And I can understand it would be a very difficult thing for many women to have this ugly, if you will, dressing on their arms.
Chelsea, David, thank you all for your presentation and educating us. Congrats on the inspection yesterday, too.
Thank you, Rob.
And there's some syrup. We appreciate it.
Thank you very much,
Thank
guys.
you.
I appreciate it.